Hi everyone. We've got a short lecture on trauma-informed care here. Let's start off by talking about what is trauma. So trauma is this idea that we can experience things that are intense and overwhelming. And as a result of that experience, there's a loss or a threat to a person's physical harm or emotional well-being. We know that trauma can occur really at every time. Trauma can be something that occurs in a single event, or it can be something that occurs repeatedly over the course of many years. And certainly we know that people can experience many different kinds of trauma, either in singly or in combination. I've got some examples here coming up in a second. The hallmark of trauma is that it overwhelms a person's ability to cope or sort of tolerate that or the emotions and feelings attached to that particular moment. There may be some effective but unhealthy ways of coping in the short term, but these can cause harm in the long term. Let's talk about some examples real quick. Obviously, something like physical abuse or emotional abuse, sexual abuse, these things can happen in childhood or adulthood. A couple of specific examples to childhood, there could be neglect or abandonment, and these would be sort of examples of kind of a chronic trauma, food insufficiency, lack of money, and then sort of single traumatic events that occur in childhood could be something like death of a parent or a divorce, and then we get into things that could either be chronic or single that are things like drug addiction, substance abuse, parental incarceration. Then, of course, across the lifespan, people become survivors of rape or survivors of serious medical illness, that kind of thing. Let me just expand the. There we go. Now the screen recorder is capturing all of the words on the slide. So then, other sort of specific examples of trauma are things like war or combat, either as a soldier or a civilian, fleeing one's country because of religious persecution or cultural persecution, often is associated with trauma. Then there's catastrophic losses. These things are often called, extraordinary acts of nature or things like that. So mudslides, tornado, forest fire, that kind of thing. And these are especially considered trauma if they result in a loss, like a loss of a home, loss of a pet, loss of a person, loss of some component or loss of some component of an identity. Going with this example, witnessing horrific events can also be trauma. Hearing about a horrific event that happened to a family member or someone close might also constitute trauma as well. So one important thing to note, though, is that trauma is not the same thing as stress. So the technical name for trauma is traumatic stress. And again, this is not the same thing as stress. This is a complicated kind of discussion that's still being worked out in the literature. There is quite a bit of disagreement over what constitutes traumatic stress. Most people are coming down on the side that trauma can be subjectively defined. So two very similar events that occur to two different people that result in some kind of a significant loss might be defined as traumatic by one person, but not as another person. So despite, though, the fact that there's that trauma and traumatic stress has this subjective definition, it typically must include a threat to a person's integrity, whether that's their bodily integrity or their emotional or psychosocial integrity. So if going along with something like this, we could think about things that are stressful as an upcoming test, an upcoming bill that you have to pay, a job interview. These things are all stressful. They are not the same, though, as traumatic stress. So traumatic stress, again, just as a review of the previous slides, things like victimization, a natural disaster, a sudden loss, or a death. This is not to minimize the impact of regular stress, but regular stress doesn't include a threat to a person's bodily or emotional integrity. like a traumatic stress is. So a traumatic stressor does. So it's important to sort of hold this distinction. This doesn't necessarily devalue the significance of regular stress, but it's really to sort of acknowledge that traumatic stress and stress are really different things. So let's talk about sort of the prevalence of trauma, and the study, the sort of landmark study that's used to sort of establish the prevalence of trauma is the Adverse Childhood Experiences Study, the ACE study. This was a collaboration between the CDC and Kaiser Permanente. Kaiser is they have a couple different branches, but probably the most significant thing they do is they are a health insurance company in Southern California. So in the 90s, they did a 10-year study that involved 17,000 of their members, and it was through this study that they developed the Adverse Childhood Experiences Inventory. Now, there is a little bit of controversy over whether or not the adverse childhood experiences all constitute trauma. They probably all don't constitute trauma, but nevertheless, the point here is to sort of establish the prevalence of trauma, which we'll do here in a second. So those 10 ACE questions asked about abuse and neglect, divorce, substance abuse in the family, violence, homelessness, lack of food, poverty, a family member in prison, a family member with mental illness. I don't have the ACEs questions in here, but they're widely available online. You can look them up. So with respect to prevalence, though, of the 17,000 respondents, 1 in 4 had 2 ACEs. 1 in 16 was exposed to 4 categories of ACEs. There was just under a quarter were sexually abused as children. More than 50% of women, much more than about 2/3 of women, experienced abuse, violence, or family member. And women were much more likely than men to have experienced 5 or more ACEs. So all of this is really just to establish that traumatic stress, which was once considered extraordinary, is now really regarded as commonplace. And it's commonplace doesn't make it a good thing, that it doesn't diminish its significance, but it's no longer something that happened infrequently or in extraordinary circumstances. So the ACEs study ended in the 90s, which is about 20 years ago now. But recent epidemiological studies that use the ACEs and use other measures of traumatic stress basically continue to confirm the prevalence of traumatic stress. As I said, it's really traumatic stress now is commonplace for people. But it's also important to note that traumatic experiences are more common among marginalized groups or people with minority statuses. So this was true in the ACEs study with women, more likely to report more ACEs and reporting more ACEs in general. And this is especially true among other groups, LGBT communities, people with learning disabilities, people of low socioeconomic status, and so on and so forth. Typically, like I said, groups with minority statuses tend to report more trauma. So trauma has a significant impact over the course of the lifespan. It changes the architecture of our brain. It results in social, emotional, and cognitive impairment. And this is all stuff that Felitti and Anda reported in their ACEs studies. Felitti and Anda, of course, were the primary investigators on the ACEs study. Trauma is associated with the uptake of health risk behaviors like smoking, eating disorders, sexual promiscuity, self-harm, substance abuse, and in time, the uptake of these health risk behaviors result in behavioral health problems, health and social problems, and ultimately early death. So this slide here, let me just move myself real quick. This is actually a New York State OASIS slide. But this essentially is their summary and interpretation of the adverse childhood experiences thing. And so the idea here is the adverse childhood experiences accumulate and progress into these, the different levels of this pyramid here, which ultimately culminate in early death. So this is really one of the things that was used to justify adverse childhood experiences generally, and trauma generally, into the sort of public health crisis, that kind of thing. So let me just move myself back up here. So what I want to talk about in the course of these next couple of slides here are basically symptoms of trauma. Now, post-traumatic stress disorder, there's actually an error on the slide I should fix. Post-traumatic is actually one word, not two, as I have it there. Post-traumatic stress disorder is only one specific outcome of trauma, but as the ACEs and other studies have shown us, there's a variety of behavioral and emotional health problems that emerge, but we're just going to talk about a few specific ones here in a second. These include reliving the experience, emotional numbing or avoidance, and then oversensitivity and irritability. So, reliving trauma typically takes the form of intrusive memories, nightmares, daydreams or flashbacks, exaggerated physical or emotional reactions, and dissociative experiences. That's feeling disconnected from one's body. When a person dissociates, oftentimes periods of time will elapse, and people are unsure of what it is they did, or what it is that happened during those times. So we're not making memories. We're not sort of conscientious of what's going on. Now, people dissociate at different times. Watching movies or driving. Or just, sort of relaxing. And dissociating is not necessarily a bad thing, but dissociating in the context of a traumatic stress is a bad thing. And it's sort of related to all of the problems that we're talking about here. Avoidance and numbing happens when people feel detached. They isolate themselves, but they feel detached from people, places, and things. Their emotional range is much more limited. There's a loss of interest in things that were once considered pleasurable. There's isolation. There's significant effort involved to not do certain things or avoid certain things or talk about certain subjects. And then lastly, trauma symptoms are associated with sort of oversensitivity and irritability. That's an exaggerated startle response, being on guard much of the time, insomnia or sleep disturbances, outbursts of anger, difficulty concentrating. So what really does the prevalence data, both of trauma and the prevalence data of trauma symptoms, tell us? The main thing, again, I don't mean to sound like a broken record here, but the main thing is that trauma or traumatic stress is much more common than we once thought. And that's really leading our profession and other helping professions to acknowledge that we need to take into account trauma symptoms in our behavioral health treatments. So majority of children in psychiatric and adults and children in psychiatric settings have trauma histories. That's true for both inpatient and outpatient. The more than 50% of people with substance use disorders have trauma histories. And that's actually true. The inverse is true as well. So people presenting for trauma treatment often have substance use problems as well. And then it's very common for people involved in the juvenile justice or prison system, correction system, to have trauma histories. This, of course, is all related to this idea of early death, but it's also, which is sort of the end of the line outcome. But there's a lot of other problems that happen in between the traumatic stress and the symptomatology and then the early death. And that has to do with behavioral health problems, involvement with the criminal justice system, offending, so on and so forth. So what this all got people who think about this stuff thinking is that the experience of trauma throughout the life course is important, and it influences who we are and how we act. What this means is that we need quality healthcare systems, quality human service systems, quality social safety net systems, so that we can address the impact of trauma in our clients and the people involved with that organization. So, what we get to are the 5 principles of trauma-informed care. And the 5 principles are safety, trust, empowerment, collaboration, and choice. These are not words that are sort of difficult to define. I'm going to talk about how they're operationalized here in the course of the next couple of slides. But these are the 5 principles here, right? So these are all of the things that clinicians or organizations try and bring in to their interactions with clients. They try and bring in a sense of safety, a sense of trust, a sense of empowerment, a sense of collaboration, and a sense of choice. And so what that leads to are sort of a re-envisioning of the way we do things. And that, for example, means moving from congested areas that are noisy to treatment and waiting rooms that are comfortable, calming, and private. Signage that is confusing to signage that is sort of helpful. And so that's sort of a more of a structurally oriented question, but maybe a more clinically oriented question is the sort of classic trauma-informed evolution is what's wrong with the person to going to what happened to that person. So asking really for an understanding of how harmful events may have led to current problems. So again, that sort of classic question is what's wrong with you to what happened to you. It's sort of relocating the blame away from the person onto that personal history. So trauma-informed care is not really, a couple of final thoughts here. Trauma-informed care is not really an intervention theory, although it does have some implications for intervention. What it really is a way of approaching work. It's a mindset, it's a lens, or it's a worldview. And to that end, trauma-informed care is really often used in conjunction with other theoretical orientations. Especially theoretical orientations that are more prescriptive with respect to how clinical work is done. Trauma-informed care is also a way to organize treatment systems. Those treatment systems might be hospitals or clinics, behavioral health systems, that kind of thing. And when that's the case, trauma-informed care also dictates that we have to support employees. We have to be trauma-informed towards our employees. So there's a big body of work with trauma-informed care that's designed to reduce burnout, secondary traumatic stress, and that kind of thing. The good news about trauma-informed care is that it has huge stakeholder support. I mean, New York state systems have bought into it. Many other state systems have bought into it. Federal systems are buying into it. Large hospital systems are buying into it. And there's a good emerging evidence base. So work has essentially been done to look at client outcomes and agency outcomes before and after implementing trauma-informed care, and the outcomes are good, and that's important. That's what sort of trauma-informed care needs. So there's good stakeholder support and good emerging evidence base. There's a lot of work being done sort of now with some other interesting variables. They have to do with things like moral injury and institutional betrayal. These are all of the different ways that traumatic stress can affect people throughout the life course. So, as always, thanks for watching. If you have any questions, let me know.